I'm going to now turn it over to Dr. Leider to address his comments.
Thank you so much. There's a lot going on in population health, and today I'm here to talk to you a bit about a slice of it and meeting the needs of the 21st century governmental public health workforce. So our best estimates are that over the past 10 to 15 years, the size of the governmental public health workforce at the state and local level has fallen by over 40,000 staff. Last year, based on composite estimates, we think we're a bit over 210,000 at state and local, and a bit more at the federal level, though, of course, being able to measure state, local, tribal, and territorial, plus federal gives us a best sense of governmental public health within the United States. And we can see that there's tremendous variety. The little circles you see are health departments at the city or county or multi-county level across the US. The bigger they are, the more staff and FTEs that they have. And there are some really big local health departments, and they serve a large slice of our population, but most are quite small. And so how we think about what these health departments do, what the needs of the workforce are, is probably going to be pretty different based on not just geography, but also the size of the workforce. Because public health is a field and not a discipline, we have a number of different kinds of positions, some of which are very technical and scientific, some of which are more administrative. And we see these across the workforce. Some of them might be very specific, like preparedness and emergency response. Some may be a bit broader, like program director or agency director. When we look to surveys like the Public Health Workforce Interests and Needs Survey, we can see a pretty good diversity of specific occupations. That when you look and you see, well, there are an awful lot of nurses, of environmental health workers, of clerical staff, and so on, that only accounts for kind of a small slice of the workforce. That means we have an incredible variety of disciplines, all with different training, different backgrounds, and different needs as workers within the workforce. One thing that unites these workers, though, is a relatively high intent to leave, whether for quitting and involuntary separations in that way, or for retirement. Our workforce has been indicating high levels of turnover for years. So these data are pre-COVID. We're really waiting for the latest round of PH wins that should come out pretty soon, within the next month or two. But even before COVID, we were seeing that a substantial amount of the state and local workforce was indicating they were thinking about leaving in the next year. And what anecdotal evidence we have right now from COVID suggests that turnover has been higher than ever across health departments, and more broadly, the Great Resignation or the Great Reshuffling has seen substantial change in macroeconomic conditions. When we think about why folks are leaving, and again, pre-COVID, that has a lot to do with big picture job satisfaction, pay satisfaction, and kind of down the line here, right? This is what research within our field has shown. But one of the things that we wanted to make sure we talked about today was the fact that our staff, that public health is not monolithic, that folks are quite different in the way that you have, you might expect to see in the private sector or the public sector more broadly. So by that, I mean, there's not just one reason that people say they want to quit. This slide shows you results from a latent class analysis of folks who were saying that they were thinking about leaving. So essentially groupings for why that might be. And you can see that there are some folks who are looking for greener pastures, right? Who feel like a lack of opportunities within my organization and pay mean that I'm looking elsewhere. But even more still are or were burned out, felt like benefits had weakened, felt like there wasn't good opportunities for growth. And then this third class, which we'll just call dissatisfied generally, or holistic just dissatisfaction, means that, you know, across those who were thinking about leaving a few years back, there wasn't one single reason. It wasn't just pay, though pay was, of course, the largest reason. That there's a number of areas that health officials have control over, or leadership and management, where you might be able to make a bit of movement, even if you can't on pay. So what skills might we lose? What skills have we lost? Well, One of the other things that PHWIMS lets us do is look into the self-rated knowledge, skill, and ability of staff, those who are thinking about leaving, who are thinking about staying, and seeing what might we need to replace the folks that want to leave. So among non-supervisors who thought that they might want to leave, we have about 35,000 folks who said that they were proficient or expert at communicating, another 30,000 that felt they were competent or expert in collecting data for decision making. So I'm not going to read all of these, but the idea here is that we have not just tens or hundreds of thousands of years of experience that we lose during a kind of mass exodus like we have experienced, but that there are specific skills that we're going to need to train up or replace with a new workforce. So what's the level of education associated with those who are leaving, who might replace those who have left? One thing we can observe is that a relatively low percentage of the workforce, governmental public health workforce, has a public health degree, about 14% across states and locals, which is in some ways a very surprising number, because you might expect more folks to have a public health degree of some type. But keep in mind, again, governmental public health agencies accept staff with all sorts of backgrounds, have folks do all sorts of positions. Even among public health science staff, though, the amount of folks who don't have a public health degree is quite high. What's very interesting, though, is when you are looking at staff who are younger, who say that they want to leave, they are much more highly educated in public health than their peers who are older that are saying that they want to leave or retire. So what that says to me is that the new generation, you might expect to have higher levels of educational attainment, but that if you're losing folks who are younger, you're also losing a highly educated workforce. In theory, we should have plenty of students who become graduates that could replace these folks who want to leave and do something else. In 2020, we have observed something like 36,000 degrees at the undergraduate and graduate level in public health in the United States. There has been tremendous growth in bachelor's degrees and pretty substantial growth until about 5 years ago in master's degrees. That's leveled off and actually has started to decline slightly, though COVID might change that. So the question is, if we're getting something like 36,000 degrees conferred per year in public health, well, couldn't that just immediately solve our workforce problem? In reality, no, because a relatively small percentage of public health graduates go into governmental public health. The best estimates we have from the schools and programs of public health that say that somewhere between 10 and 20% of public health grads go into governmental public health as their first job out of school. Most go into not-for-profit or healthcare for the master's students, and then the undergraduates are going into for-profit at higher rates, which is pretty in line with undergraduates more broadly. But that means that when you think about bachelor's versus master's versus doctoral students and what they might do for the public health workforce or the population health workforce, you should not think of these students as monolithic either. There's going to be substantial differences based on their level of education, where they are geographically, and earning potential alongside debt. So before COVID, we thought that about 1/3 of the workforce would leave or retire. Likely that's happened at least, if not more. There's estimates that between 2017 and 2021, turnover was about 2 to 3 times higher than 2014 to 2017 in governmental public health. So we've talked about who might replace those folks. Largely, it's going to be probably non-public health degree conferrals, but it's hard to know for sure. If we do a better job competing for and then retaining public health graduates, we might be able to have them replace a substantial amount of the workforce. So how can recruitment be competitive? It's not just about salary, but it's about how fast can you hire. I think there are a number of other items we're going to hear about today that will make a big difference, including how central justice, equity, diversity, and inclusion is in hiring practices. And then finally, what happens in the long term for public health education? There was kind of a slowdown experienced in master's education, bumped up by COVID. What will happen next? And what skills will the workforce need? So that's my presentation for today. Jeff, back to you.
Thank you so much, Dr. Leider. Appreciate your really helpful remarks.